Bismillah ar-Rahman ar-Rahim. Most of diabetic foot lesion precursors, which is, early lesions, are iatrogenic by missing diagnosis or patient education or wrong management. Missed early infection, missed injury, missed wound healing factor, missed silent fracture, missed claw foot, missed aggressive attack of plantar callosity, and missed tight shoe syndrome. This is the claw foot. You have to be good observer. Don't miss the high pressure points, the callosities, and don't forget to do the proper investigations for all claw feet so that you will find dislocation here and melting of the fat so that it will be an ulcer within days or months. Also, please be a good observer to see the hump here. If you can see the hump here, this is the dislocated head of metatarsals, which is making bag. In the West, they call it pregnant forefoot by the heads of metatarsal. Then the callosity appear, and the good observer will remove it just to have a big hole in the foot and to let the patient have very difficult ulcer to find, because the callus is good. It's a protective tissue against ulceration. But if it is painful or infected, we have to interfere. Common mishaps with early D foot lesion is aggressive plantar callosity attack. To find these results, please don't do it. If you have a patient like this, apply the color-coded protocol to find out the etiological factors, which is usually curable. Here, they didn't observe that there is osteomyelitis here, and they missed it, and it became chronic until we found and corrected the blood quality, the blue, the bone, which is white, the yellow, and the blood quantity, the red, so the patient is cured. Also be good observer for the silent fracture, which is called the stress fracture. Simple edema. You have to follow the rules and to do the lab and the X-ray to find the simple fractures. Fractures, if you miss, it will make hematoma and osteomyelitis proximal and distal, dead space accumulation of pus, a compartmental syndrome, and the spread of infection. Also early lesion as thermal iatrogenic injuries. دي واحدة ست كانت حاطة رجلها على الدفاية. Another one who removed the callus and then he put a pack. Please never to put a pack in diabetic foot wound. You are not going to make it a Molotov bomb. Why to put a pack? They said to put a pack so that the pus will come out. No, it will not come out. The pus will be accumulated inside because there is an anaerobic organism waiting for this. So you have to correct the etiological factors, then to excise the head of metatarsal. After 1 week, it will be closed. Also, the iatrogenic injury is to miss the diagnosis of osteomyelitic bone, just to drain and to leave it. And after that, you close the wound by stitch. This is iatrogenic injury. Iatras means doctor. This is doctors are destroying the foot of the patient by disregarding the osteomyelitis and making sutures. Please don't do that. Also another one, he did amputation and he left the bone stump. Then he closed by stitch. Please never to do this. This is iatrogenic injuries. Also this one, but in Reach Hospital, they use the staples instead of this one. This is the early tight shoe syndrome, which if you leave, he will have severe ulcer and wound infection. Why the patient like the tight shoes? This is another thing we will discuss later. This is another type of infection. He came to me 2 months with widespread antibiotics and local antiseptics, and the infection is increasing simply because it is fungal. And when I stopped the treatment, the patient healed without any treatment. Please be observant. A common missing limb saving criteria, I will tell you about a case, 72 years old male patient, diabetic, presented with distal phalanx 3rd and 4th gangrene with mild infection or minimal infection. Then, according to the color-coded protocol, we found that he had blood quality factor, bone factor, blood quantity, and tissue loss. We corrected the blood quality, which was 8% gram hemoglobin, but the hematocrit was 20, so it is really 6 gram only, and this is incompatible with any healing. We corrected that to be 9 TLC, but as we said, this is after correction of the blood quality. Then the blood quantity we corrected by the endovascular intervention. This is the angio, where there is the 3 tibials infrapopliteal were affected. We did the angiography to the arch even, and the arch is reconstructed again. So the blood quality and the blood quantity are regained, but we forgot to remove the infection. The minimal infection, when we revascularize the limb, will be major infection, will be severe. And if you neglected 12 hours or 24 hours, you will find the patient in the ICU with septicemia. And this is after 12 hours only. This is, and the TLC raised immediately to 18,000. Serum creatinine raised also. Serum albumin dropped because there is sepsis, and random blood sugar raised. And this was an emergency because we didn't remove the infection just after the successful revascularization. So he had localized amputation because of that, and with suction we succeeded. Please remember that there are 4 other important factors than the blood quantity have to be detected and saved. And according to our published study, we found that one specialty-minded management means 100% limb loss, 2 specialty-minded management, 80%. Our protocol management with detection of all etiological factors, 72% salvage of cases presented for major amputation. Recommendation for after successful revascularization, please don't leave the patient after revascularization with mild infection. After your successful revascularization, infection with flourish, septicemia an hour, he will be in septic shock soon, and you will do major amputation in limb with pedal pulses just to save the life. So please, don't title your patient with your respected specialty. Invest in brain and education, regular orientation and seminar to the nurses and to the fellows, and to make the patient deserve the best treatment you can do. Everybody agree for that, but unfortunately I don't agree. Patient deserve the best that should be done, not that what you can do. You have to have the best, not because I can do femoropopliteal only. If you have tibial disease, I will do amputation. No, the patient need the possible that can be done, not that what I can do. Don't limit the food salvage to your limited personal or specialty abilities. We, thank God, created the International Diabetic Food Salvage Fellowship, which collaboration between Diabetic Food Salvage Egyptian Foundation, Cairo University, and Chennai University in India, and 2 groups were succeeded in that. It's WHO accredited, and this is everything. I'm sorry to be late. Thank you very much.